Well, ladies and gentlemen, as mentioned, today's really a focus on nursing. I also want to say, just before I announce the next keynote speaker who will dive deeper into this focus area, that the innovation area that I mentioned at the outset of this morning is not just by UMC Plus, but really by nurses all over the country who are showing their innovations. So it's really a joint effort, a national effort, to make understandable what kind of innovation is happening across the country when it comes to nursing, and I do encourage you to take a look. But for now, I'm very excited to dive into this next keynote because we are inching our way into the core of this topic. Please put your hands together for Dr. Eugene Waterval, Director of Research and Education at Nemours Children's Hospital in Orlando. Welcome from across the pond.
Thank you. Thank you very much for having me here at this conference. I would like to thank the planning committee and especially Marjolein Hemels for inviting me. It's an honor for me to be here. So let's talk a little bit about virtual nursing. But before we do that, I want to start off with one of my favorite quotes. Every system is perfectly designed for the results it gets, right? This is one of my favorite quotes because all these infrastructures, healthcare systems, technology systems, they all render some results. And think about systems very broad. You can think about healthcare system, a hospital system. You can think about your unit as a system. And maybe if you have a professional nursing governance committee, that could be a system as well. So Don Abedian really looked at systems a little differently. He created a model in the 1960s where he really focused on healthcare and outcomes for healthcare. The structure, process, outcome model is still applied in many organizations today. And when you think about structures, it is, again, a hospital system. It can be an infrastructure for technology. It can be a unit. It can be anything that really creates an infrastructure for provision of care. Then you have processes. Out of these structures come processes. Processes are activities to really deliver the outcomes that we want. What he really wanted to show is that all of these three pieces are connected. You got to have a good structure and then good processes, activities. So think about decision making. If you are a nurse and you have to make decisions about care delivery, then those are processes, right? And then what are the outcomes? Because you want to achieve certain outcomes. And to me, the outcomes is what it's all about, right? But you got to have the right structures and processes. So one of the things you can think about nursing, we have nursing care delivery models. And I'm sure you've been to nursing school, you know all about that. Primary care nursing, still a very prominent model where the nurse has primary responsibilities for the care delivery. Think about team nursing, a team of providers. It doesn't all have to be nurses, it can be nursing assistants. They provide care to a group of patients. Other models could be maybe episodal care models, which you see in the emergency department, where they only take care of patients in a certain episode that they need care for. And these are also include structures and processes, right? Wherever you deliver the care, the location, it is maybe the unit, it can be maybe through a shared governance council on your unit, where you are making decisions about delivery of care. So think about that, and then what are the outcomes? So I work at Nemours Children's Health in Orlando, Florida. Nemours Children's Health is a unique pediatric organization that is spread out over 4 states in Florida, and not in Florida, in the United States. The main hospital is in Delaware, and then we have a second hospital in Orlando. And then there's multiple clinics that are spread out over those 4 states. And then we also have partnerships within hospitals where we have providers that provide pediatric patient care. The hospital in Orlando opened its doors in 2010. And Nemours is based on a foundation. Alfred DuPont was a philanthropist, a millionaire, who donated a lot of money to a foundation and said, I want you to use this money to provide care to pediatric patients. And the whole vision of Nemours is we want to create a healthy generation of children, because you create a healthy generation of children, you create a healthy generation of adults, and you create a healthy society. That really appeals to me as a professional nurse. It really aligns with the values, and that's why I work there. Nemours is also known for leveraging technology. So when they opened the doors in 2010, they said, we're going to use state-of-the-art technology that's available that will take us into the future. And one of the things they implemented was like a type of command center. We call it the Clinical Logistics Center. The Clinical Logistics Center includes 2 programs. One is a remote monitoring program, and the other program is our virtual nursing program. As you can see here on the screen, in the front we have 2 nurses. They're sitting behind the computer. Those are our virtual nurses. And then in the back, closer to the big screen wall, you see our paramedics that are specially trained to do remote monitoring. Each paramedic can monitor about 50 patients, and these patients are non-critical care. Critical care monitors their own patients, but these are acute care patients, not only in Orlando, but also in Delaware, which is about 1,400 kilometers north of Orlando. They monitor vital signs, oxygenation status. They can also monitor pediatric early warning scores. They monitor sepsis scores. And they are in constant communication with the nurses at the bedside, right? Think about that, right? Because any remote or virtual program, you still need to have hands on the bedside, right? You still need to have hands on that patient. Also, they monitor logistics, operational logistics, making sure we have throughput of patients, so they're part of that as well. And this program was started right away. Our virtual nursing program started in 2023, but let's first have a look at how that initial Clinical Logistics Center worked, and this is a video from 2014.
My name is Mike McCarthy. I have a son that is about to turn 2, and he had spent about 2 weeks here at Nemours. He had a febrile seizure.
The logistics team was watching him the whole time, watching his monitors and watching how he was. Middle of the night, we're both asleep. The nurse comes in to check him, and he's fine. She walks out of the room. All of a sudden, the light comes on in the room.
Within, I want to say, half a second, you can hear on the, basically on the intercom, you can hear a voice saying,
Where the logistics team is the nurse in the room. And so we knew right away that something was wrong, and so we got up and noticed he was seizing.
And then when I knew it was an appropriate time to video, I videoed in, and I was talking with the nursing staff that was there. We were able to initiate a rapid response pretty quick.
This team of people was in the room treating our son within seconds.
So the logistics center essentially is an extra set of eyes and ears for the upper floors. Any kind of cardiac dysrhythmias we see on the Philips monitor or oxygen deficits that we see on the monitor will give us immediate red flags of we need to audio into that room and check and see what's going on.
They pretty much prevented more damage from being done because they noticed so quickly and responded so fast.
that for me, that makes me feel a lot safer about everything.
We have a child who's probably 80% recovered. He's walking again, he's using his arms, he's functioning like a typical child. We'll be forever thankful for the team at Nemours for what they've done.
All right, so the remote monitoring program and the virtual nurse program use the same technology. And recently, I think it was last year, we acquired new in-room cameras that are also AI-enabled. And so every patient room has a camera built in. These cameras are not constantly on to monitor patients. As you can see in this picture, the camera is pointing upwards. And in case they notice something or the virtual nurse needs to basically log into the room, a chime will go off, and then an auditory comment will be made, like, I'm so-and-so, I would like to turn on the camera, are you okay with that? I need to do a quick assessment. So then the camera comes on and it just tilts forward, and then you can see the patient, and the patient can see the virtual nurse or the remote monitoring tech on the screen in the room. So there is audio-visual communication. The cameras are very high definition. If you want, you can zoom into the patient all the way to check their pupillar reflexes. That's how high-tech this situation is. Now, the virtual nursing, as I mentioned, used the same type of technology that you just saw in the video. The two components, the two processes that our virtual nursing program uses is mainly admission, documentation, and discharge documentation and teaching. So, as we all know, nurses are really busy. There's a lot of documentation. I know Dr. Fernandez talked about how many hours we spent on documentation, and admission and discharges is really where a lot of that documentation occurs as well. So in order to alleviate the nurse, they said, okay, let's have those two pieces of processes for the virtual nurse. By the way, the virtual nursing program was a program designed by nurses, by frontline nurses. So the virtual nursing program, they do have their own council. They have a shared governance council, and they basically set up the program in 2023. They all had input on what to do, how to create processes, what guidelines do we have, how do we interact with our patients. They received special training, especially how to do education through this remote program. And so documentation for admission, very time-consuming, got to go through all the checklists, screening tool, you have to talk to the patient. You have to talk to the patient about the virtual nursing program, about the remote monitoring program, so they understand the camera is not turned on at all the time. And then the discharge piece. Discharge piece is really important because we want to provide discharge education to our patients, because we don't want them to come back because they did not understand the discharge instructions. Nurses at the bedside are really busy. And then at times it can be like, okay, I have to rush through that discharge education, right? I don't have time because I got this coming, and it doesn't matter how calm you try to be, patients notice that. So, and they might not be asking you a lot of questions. The virtual nursing program is very effective in that because they remotely log into the system, and the patients and families, they are more comfortable talking to that virtual nurse because they know that nurse doesn't have to take care of that other patient, because you are the only one talking to that virtual nurse. So they feel more comfortable with that. So they take more time to do the discharge education. And when they set up the virtual nursing program, one of the things they said, okay, what are outcomes, right? Because I talked about outcomes. It's all about outcomes. We really want to know, so what, right? And they said, okay, what can we as nurses measure for outcomes? So they decided to look at patient experience scores. Now, in the US, all patients that are discharged getting a survey, and the survey has a bunch of questions in it, and there's also a bunch of nursing-specific questions. So they said, let's look at our nursing questions. What can we do? Can we improve those scores? The other thing the organization was a little struggling with was readmissions to the hospital. And in the United States, readmissions for certain diagnoses within 30 days, those do not get reimbursed by insurance companies. So there's really a lot of focus on preventing readmissions because it can save you a lot of money, and then, of course, it's a lot of misery for the patient as well, of course. Now, so they said, okay, so our outcomes will be patient experience scores, and let's look at readmission rates. All right, so having said that, I got this cup from my professional development manager. I love her, Barbara, she's great. And she understands me, right? Because she said, oh, I want to start this educational program for our nurses. And then my question is, now, it's a nice story, right? Great, so what are you going to measure? Show me the data, right? Because we can implement any type of program, but so what, right? What difference does it make for our patients? Because that's what it's all about, right? Or our nurses. So it's all about data, it's all about outcomes. So I want to go back to the 1990s. So I was born and raised in the Netherlands, and I worked in the Wevelziekenhuis. And I'm sure there's still some people here from the Wevelziekenhuis of Zuiderland. Anybody from Zuiderland here? Yay! Okay, all right. So I worked at in the ICU. And that was in the early 1990s, and we had some physicians there. They were very innovative, I should say. And we had a very engaged nursing team. And they said, well, we really want to provide the best possible care to our patients. So the discussion started, so what is quality of care? So how do we know what type of care that we deliver? How do we know how good our quality of care is? So there was a lot of discussion going on in the 1990s about that, but we were not measuring anything related to specifically nursing care. So I moved to the United States in 1995, and they had the same discussion. It was about quality of care. But there were two movements going on at the same time. And one, Dr. Fernandez already said, the 1999 Institute of Medicine report, To Err is Human, really was showing us that there were almost 100,000 people dying, patients dying in American hospitals. And there were similar results in European hospitals. That was a huge wake-up call, right? I mean, you don't go to the hospital for a simple procedure and then end up dying. That is not the quality of care that we want. So there was a big focus on quality of care. The other thing that was happening for nursing as well. What is quality of care for nursing? And the American Nurses Association said, we got to measure quality of care. So they started a database called the National Database for Nursing Quality Indicators. And they said hospitals can contribute their quality of care data that's measured and collected in using very specific protocols. Then that gets entered into the database, and then we generate a benchmark, a national benchmark, so we can benchmark, compare ourselves to a national database. That national database became really important for the Magnet program. Not sure if you're aware of the Magnet program. The Magnet program is really about well-trained nurse leaders that develop a healthy work environment, a supportive work environment through a professional or shared governance structure where nurses have a voice in decision-making about the care they provide. And that came out of a study that was done in the 1980s, and there were certain characteristics that these hospitals had where they had good outcome and low turnover for patients. That's why it's called the Magnet program, because not only patients but also nurses. So nurses were staying in those hospitals because they liked working there. They felt they were supported, they had good quality of care. And that quality of care then was being measured. They integrated that in the 2008 Magnet model, where they said there's three quality indicators or three indicators that you have to be successful with in order to get this prestigious Magnet accreditation. There's about 10% of hospitals in the United States that have that accreditation. It's actually growing worldwide as well. As you can see, in 2011, there was Saudi Arabia had their first hospital that became Magnet, and I think we have currently about 14, 15 international Magnet organizations. They use the same standards as in the US, so there's no difference there. So the three indicators, you want to measure your nurse satisfaction. If your nurses are not happy, you're not going to get good quality of care, right? So nurse satisfaction is really one of the key indicators. If you don't have good nurse satisfaction, you can't move forward. Then you have your quality of care, right? And how is the quality of care being measured? So what is quality of care of nursing? So those quality indicators, we're looking at central line infections, okay? After the physician puts the line in, it's nurse's responsibility to manage that, right, to prevent infections. You're looking at urinary catheter infections, you're looking at patient falls, you're looking at pressure injuries, prevention of pressure injuries. It's just something nursing, it's prevention of pressure injuries, right? So those were some of the indicators. Right now they have about 250 indicators, including a virtual nurse indicator. Now, NDNQI is not the only database. There's many other databases you can use. I know Europe has been working really hard on that. There's several databases in Europe where you can enter your data for comparison as well. So data is really important. So what is the outcome of your program? So one of the things that we talked about in our virtual nursing program, looking at our readmission rates. So we have a very large Hispanic patient population in Central Florida. And one of the things that we noticed when we looked at, after implementation, we looked at our readmission rates for our patients in general. We saw a decrease in readmission rates, but when we did some more population deep diving, we found that more than 50% reduction of readmissions for the Hispanic patient population, which was enormous, right? This was a very, very good success indicator, and we contribute that to the success of the program, right? Our nurses are involved, but also what we were able to do through the technology, we could basically link any translators into the program. So you could, as a patient or parent, you would be in the room, you could see on the screen the translator, and you could see the virtual nurse. We can even link the parents in if they can't be able to make it to the hospital. We can link them in, and they can be on the phone. So we can all be in that virtual room providing that discharge education. So that was a huge success of the program. But we're moving forward, right? There's more things to do. So you're looking again at these structures and processes. Other outcomes you can measure are lengths of stay. You can look at reduction of patient falls. This is what you find in the literature. You can also look at prevention of deterioration. So our remote monitoring program, one of the success indicators was, can we reduce our cardiopulmonary arrest events? And we did. Basically, because they were monitoring the patients, so they could detect early if there was some type of deterioration going on, and they would call a rapid response team after consulting with the nurse, obviously, because you can't always rely on those type of technologies, right? We're not there yet. And they would call a rapid response and prevent deterioration. So we saw an increase in rapid response calls and a decrease in cardiovascular arrest events. Another indicator that we can use is nursing workload, right? It's all about nursing workload. That's why we wanted to use the program often. A lot of organizations want to use it to reduce workload. The studies right now don't show a really strong result in a reduction of nursing workload because of the virtual nurse programs. What we basically see mixed results. And I don't know why, but I can understand, maybe it's because we don't have a gold standard on how do we measure nursing workload. There is none. Everybody measures their own way. And then maybe we reduce the documentation time for nurses, but then something else gets replaced, so the nurses will still continue to be busy with the work. So it all depends on how you look at it. So I mentioned data is really important. So let's have a look at what can happen. That's one of my favorite videos, to be honest with you, because, I always say sometimes, if you're talking about evidence-based practice implementation, planning is really important. So, you want to make sure that you plan appropriately, because otherwise you're going to fail. Now, this gentleman did actually plan appropriately, but maybe he didn't have the right target in mind, right? And that's what I want to talk about as well. So what is your target? What is your target for making improvements, and how are you going to measure that, right? Because again, it's about outcomes. Now, what are our next steps? So the organization has AI-enabled cameras. installed in all patient rooms, but we haven't really turned the feature on. Now, just before I got on the plane, I heard that our sister hospital in Delaware has implemented AI in their cameras for specifically behavioral health patients. So think about patients with anorexia nervosa or patients that maybe are on suicide precautions. So can we then use those AI-enabled cameras to study their behaviors, and can there be some type of prediction if something is going to happen or not? I know it's being used in the adult world, where we're looking at studying movement of patients in their beds that are not allowed to get out of bed or they are at high risk for falls. So how can we then predict if these patients are coming out? So it's working to some extent in the adult world. Now, is it perfect? No, it's not, right? It's not. As we implemented our virtual nursing program and also the remote monitoring program, there were a couple of things that we noticed. We need to work on that. I don't know if you remember the picture. The camera was pointing upwards, so the lens was upwards. If you hadn't used that camera in a long time, you turn it on, you're going to have dust on it, right? So things like that really made us to look at our protocols a little bit differently. Also, I worked for an organization that wanted to implement virtual nursing. I was writing for their magnet document because that's part of the accreditation process. And I said, well, we need to have an innovation. Can I write about a nursing innovation? And he said, yeah, we have a virtual nursing program that we implemented. And this was not building cameras, these were mobile cameras. And I said, awesome, we're going to write about that. So tell me what you did. Did this, did that, and everything, and it's working wonderful. I said, what was your goal? What did you want to accomplish? Well, we want to reduce the workload of our nurses. I said, awesome, let's write that. That is really a great story. Send me the data. So they sent me the data. It was how many hours was the virtual nurse active? How many technology interruptions do we have? And by the way, there's a lot of technology interruptions. As we implemented our virtual nursing program, then started embedding everything into Epic, and then started adding the AI pieces to it. So it really created a large volume of data onto our servers. And we still, to this day, even though we replaced our servers, we still have to reboot our servers every day because they get overloaded somehow, and we don't know why, but it happens. So anyway, so they asked me, so they sent me all this data. I said, where's your workload data, right? So that really means you need to look, making sure that you're measuring the right thing, right? Measure the right thing. Think about that before you do anything. All right, so the next steps are, can we integrate AI into our documentation pieces? Can we look at predictive algorithms to prevent harm? And I know you've seen a lot of that already here at this conference about how we can use AI. One of the next steps here is looking at a hospital-at-home program for pediatrics. There is no pediatric hospital-at-home program. It's where patients are getting their surgery, they're going home, and they're getting their care there. So we want to integrate virtual nursing into that. We are waiting for approval from the state because it does require regulatory approval, but everything is ready. Our structures and processes are in place. We know what it is that we want to measure on outcomes, but we're just waiting for that. In the meantime, we do have an advanced care program at home. It's where chronic patients go home, and then their parents or caregivers are educated to manage maybe their feeding tubes or their trach, anything for those chronic patients. And then they can use the virtual nursing program, who then checks in every day, see how things are going. Do you need anything? Do we need to coordinate any care? Do we need to send a home health nurse to your home? So that program is working, but the home health program, not yet. So a lot about virtual nursing. And I want to end off with the slide that I started with. And this is your take-home message, right? What systems and what structures, processes, and what outcomes are you going to measure? That's really what it's all about. So think about, how do you do this? And then my second take-home message is, include the nurses in direct patient care, the people that are providing the care, because that will create a successful program. Our virtual nurses, they own the program. You cannot make any changes without going through them first. So they're owning the program and they're owning the data. That's all I have to say about our virtual nursing program. So I'm open for any questions from the audience.
Thank you so much. Unfortunately, we don't take audience questions, but I encourage the audience to come to you with questions afterwards,
Please do.
just for the interest of time. I have a very quick question because you mentioned in a brief moment this topic of shared governance. Can you speak to that a little bit more, because I think it's a key leadership aspect?
Yeah. Thank you so much for that question. That's really a passion of mine, because professional governance, shared governance is really important. Nurses should own their practice, so you need to be able to make decisions about your practice. This is what any nursing leadership should be supporting. You should have a structure, is it councils or unit-based councils or anything in your organization where nurses can come together and discuss their outcomes, right? So you need to make sure you have the outcomes for them as well, to look at it and to see what can they improve. And again, as I mentioned, through our virtual nursing program, that really creates that ownership, and then you can get better patient outcomes because they own the data, they own the program, and they will run with it.
Dr. Eugene Waterval, thank you so much.
Thank you.
Thank you.